Coming to the questions, my friends. Question number 1. 1 month-old child present with an immovable joint movement absent. Think about joint infections. Swelling on the thigh, extending the whole thigh. ESR found to be elevated. Child is toxic. Toxic child, absent movement, less than 5 years. I'm going to have a thought of septic arthritis. Soft tissue planes are enlarged because of the fluid. True and false for joint infections. There's a widening of joint space always there. In the initial stages, you might see widening of the joint space. But as the joints get destroyed, it reduces. Wrong. False. Staph is the most common organism. True. IND is done after culture and aspirate and antibiotics. False. Joint infection is an emergency. Cocker's criteria is used to differentiate from transient synovitis. True. Position of the hip is farther. False. False. True. False. True. False. Cocker's criteria involves different parameters which can help you diagnose septic arthritis versus transient synovitis. When we talk about question 3, synovial tenosynovitis of flexor tendon, what is correct? The fingers are extended. Wrong. It has to be conservatively managed. It's true, rarely operated. Little finger infection can spread to thumb but not to index finger. Absolutely true. Patient presents with minimal pain. No, it's severely painful. C is a better answer than B, although B is not wrong. 12-year-old male came with a swelling of lower end tibia, which is surrounded by a rim of reactive bone. So lower end tibia, rim of reactive bone, Brody's abscess. Because GCT, hyperparathyroidism, osteomyelitis, all these will have lysis. Multifocal osteomyelitis, you have both the options, SAPHO and sickle cell. Choose SAPHO syndrome. True about acute osteomyelitis, cannot be detected on X-ray before 2 weeks. Yes, you can see loss of soft tissue planes after 24 hours. You can see periosteal reaction day 7 to day 10. So it's wrong. Bone scan can detect after 2 weeks. Wrong. It can defect after 12 hours. This is wrong. Severe pain. True. Secondary osteomyelitis associated with compound fracture is more common than primary. False. Primary is the most common variety. Limitation of movement. True. In fact, movements are absent. A child present with fever and discharging sinus from the right thigh for 3 months. Identify the label structure. Deformed bone. In the cavity, you have a dead bone. They have marked the involucrum, the reactive bone outside. Tom Smith arthritis destroys capital epiphysis femur. 22-year-old male present with pain and deformity of the right lower limb. He sustained a trauma. X-ray suggestive, deformed lytic cavities, chronic osteomyelitis. In our country, everything is related to trauma. So you should not be bothered. Negative pressure wound therapy, which of the following is false? Pressure can't be in positive, it has to be negative. So B is false. Paprika sign, remember, removing the dead bone, bleeding bone is crucial in the management of which condition? Chronic osteomyelitis. In osteomyelitis of spine, most common causative organism, ortho is staph. Staph is ortho. It's not TB. If they mention India, you won't assume. But if they mention India, then mark TB. Ring sequestrum is seen in. Nowadays they're encroaching upon this area. It's seen in an infection of pinhole after a fixator. So they are encroaching upon the sequestrums. So these are some of the sequestrums. Around the pin tract and amputation stump is a ring sequestrum. Tubular is a segment involved. Hematogenous osteomyelitis. rice grain, coke or feathery tuberculosis. As long as we live in India, you will get question 1 TB. Button sequestrum, pheochromocytoma. Black sequestrum, gunshot. Bombay sequestrum, skin loss. Colored is fungal. And then linear, 1 cortex, osteomyelitis. This is what you should remember in today's world. This came in AIMS June 2020, might come again. Thank you.